Well, hello, everyone. Today
Hello.
is going to speak to us about spinal cord injuries. So welcome, David. Thank you for coming.
Okay, thank you, Kate. Just to let you know a little bit about who I am, I've been an occupational therapist since 1982, and I've worked in a number of different countries, both as a therapist and managing disability projects in Africa, in South America, in the US, and I've also worked as an occupational therapy tutor in Uganda and in Guyana. So thank you, Kate, for the introduction. I know you, Rebecca, from our time working in Guyana. Kate, I look forward to getting to know you, and also Michael. The topic we're going to talk about is spinal cord injury. It is a large topic, and it's too much for 45 minutes, because you know we have to have 45 minutes and then 15 minutes for discussion. And it's large partly because OT plays a very important role in spinal cord injury treatment, because when somebody has involvement of the hands, they need OT to be able to complete their ADLs. And also because there are so many different causes of spinal cord injury that dictate different approaches for occupational therapists. So for instance, a person who's working with a person with spina bifida is very different in terms of their treatment than somebody working with somebody who's had quadriplegia resulting from a fall. I will be honest with you, most of my experience is working with people who've had traumatic spinal cord injury. So that will be the focus. But as you may have seen from the schedule, because it's such a big topic, we do have 2 sessions scheduled, one now and one in January. So if after the first session today, I will be sending you each the copy of my PowerPoint, and you can look through it. And if there are areas that I'm not covering in enough detail for today's session, please let me know, and I'll try and include some of that information in the second session. Also, please stop me if you have questions. You can let Kate know and she will inform me. And also let me know if I'm speaking too fast or if I'm causing difficulty with my accent. Let me know how it's going as we go along. The other thing I want to say is that, do you have a comment, Kate?
No, I said that sounds great.
Okay. The other thing I wanted to say is that to me, these sessions should not be, the result of these sessions should not be only a one or a two-way transfer information, but they should be an opportunity for the mentees, the people listening, to form connections also. Many of you are working in less developed countries, and the problems you encounter may be similar, so you should try and develop connections with each other and serve as resources for each other, in addition to the mentors serving as resources. Any preliminary questions from you guys before we start? I see some heads shaking. Okay.
Oh, questions from me so far.
Excuse me? Okay. So to begin with, just a very general overview of spinal cord injury. As you know, there is paralysis in the limbs and motor paralysis, and also lack of sensory awareness resulting from spinal cord injury. We have the 2 types: quadriplegia, also known as tetraplegia, and then paraplegia, with quadriplegia being ability to use only the head and some part of the arms, and paraplegia being lack of movement in the legs and ability to use the arms. So this is just a very general outline of what a person might have based on their level of injury. Let's talk now about some of these level of injuries and what a typical patient might look like. So, somebody who has a high cervical injury, their spinal cord is injured between the C1 and the C4 level. That would be known as a quadriplegic, or a person with quadriplegia, or a person with tetraplegia. to use the person first terminology. That individual would have completely paralyzed legs with no sensation, likely to have trunk muscles paralyzed and no sitting balance and no sensation, and the arms likely to be completely paralyzed without sensation. Often, there will be problems with the lung muscles. So if the person has impairment of the muscles that operate the lungs, they may have difficulty speaking, and they may have difficulty breathing. And there will be no bowel or bladder control. So a typical patient who's had this level of injury, maybe on a respirator, is very likely to have dependency for all their ADLs. If they're in a country that has electronic devices, often they can use these devices, even at this level of injury, to open doors, to turn on lights, things like that. But they're likely to need help with the other ADLs that require physical aid. Sometimes they'll need to use some sort of a code to communicate if they have trouble speaking. It could be an eye blink code, like blink once for yes, blink two for no. It could be a letter scanning thing whereby they blink to indicate what letter they want to indicate. Or they may be able to use a computer eye scan, whereby they look at a certain place on the computer and that would indicate to the person they're talking to what letter they want to use and communicate that way. They also may be able to use a mouse stick to manipulate objects. And they will be at a high risk of pressure sores. So our role as OTs is to strengthen whatever functional muscles they have and to prevent arm contractures and pressure sores and to train the person in using whatever devices, whether it be low-tech mouse stick, whether it be high-tech communication for their communication, their mobility, and their ADLs. I will stop just a minute between slides in case people have questions. On the other hand, somebody who has a low cervical injury in the C5 to C8 area, they'd still be considered a quadriplegic or tetraplegic. They'd still have paralysis and no sensation in the legs and the trunk and no bladder and bowel control, but they should have some level of arm function. So for instance, at the C5 level, they'd be able to raise their arms up in the air and they might be able to bend their elbows, but they wouldn't have strength to straighten their elbows. Whereas if the damage were at the C8 level, they would have functional use in the arms, except for the fine intrinsic muscles of the hands. The typical patient here will use a wheelchair. They will need support and assistance to sit and transfer, at least initially. They should be able to perform most of their ADLs, although they may need adaptive equipment for moving the arms and or holding devices, depending on their level of injury. So as an OT, our role will be to strengthen what the existing arm muscles are, to prevent extremity contractures, provide adaptive equipment, adaptive techniques, work on transfers, make splints or slings, to facilitate the increased hand, arm function, and movement. Excuse me. Not used to talking so long. I did it when I was in Guyana working with the Guyanese students there, but my voice is out of the habit. Next, somebody who has an injury in the thoracic area. This would be considered a paraplegic. Again, legs completely paralyzed. The trunk strength will depend on where the level of injury is. If it's a higher level, they may not have trunk stability. If it's a lower level, they may have some trunk stability and no bladder and bowel and bladder control. So this patient who's likely to use a wheelchair should be able to transfer independently, should be independent for other ADLs, and should be able to manage a bowel and bladder program if they have adaptive equipment. So our role as OTs would be to train them to use the bladder and bowel control, the bladder and bowel equipment. We also take a large role in workplace modification. Often these people are able to work, and community mobility and home modification to operate from the wheelchair level. And then finally, The person who has lumbar or sacral damage would be a paraplegic. They would have function in all levels except for the legs. And depending on the level, they might walk with crutches or braces. They should be able to manage a bowel and bladder program. So our main role would be working on home workplace modification and community mobility. Just to emphasize, we often talk about motor function, but we need to be aware there's also a sensory loss. I'm just checking because are people still hearing me? I've lost my Zoom screen. I just have my PowerPoint screen.
I muted everyone when you're not asking a question, just so that it reduces the background noise.
Okay, okay. Any questions here with our general introduction to spinal cord injury? If not, we'll go on. I want to talk about a few medical issues first before we get into the OT treatment. These are areas that are primarily the responsibility of nursing staff, but OTs need to know about them because if a person has some of these symptoms, we need to be able to inform the staff, and there may be a few steps we can take to address the problem. So the first area is called autonomic dysreflexia, and you'll see from the quote that I've listed there that it's really a life-threatening emergency. The quote says it can lead to apoplexy, which is another way of saying a stroke, and it's caused because the person who has had the spinal cord injury not only has problems controlling their muscles and not only has sensory problems, but they have problem controlling temperature and blood pressure. The receptors that help the body maintain control of blood pressure and temperature may be impaired. So, hello, Calvin, I see you there. You're welcome.
Hi.
So such stimuli such as constipation or impaction in the large intestine, a blocked catheter, being stuck with a pin, many of these different areas can cause an abnormal response in the nervous system that will result in this autonomic dysreflexia. The symptoms we need to be aware of are a sudden increase in blood pressure, sweating in the head and arms, high pulse rate, lightheadedness, and confusion. We need to be able to aware of these symptoms, so if these happen, we can inform medical staff and we can take some steps to reduce the things that may be bringing on the autonomic dysreflexia, because it can cause stroke or heart attack. Again, we monitor, we inform medical personnel. We also sit the person up, because the problem is blood pressure has gone up, there's increased blood pressure within the brain. So if you have the person sit up, the heart has to work harder to pump blood up towards the brain, and that will reduce the blood pressure. So one thing we do if the person is lying down, we have them sit up, but we also try and figure out if there's a causal stimulus, if their clothing is tight, if they have pins sticking into their body, and try and reduce those causal stimuli. And then the next slide is just an overview of this. As you can see, it's triggered by stimuli at the T6 level or below, and these are some of the different causes of this autonomic dysreflexia. And here on the left are some symptoms above the level of injury. And here on the right are some symptoms below the level of injury. Now, as OTs, we would be most likely to see these symptoms above the level of injury. We wouldn't be best likely to see the condition of the person's legs. So the flushed face, increased blood pressure, headache, increased heart rate, or increased sweating are the things we'd be most likely to look for. Any questions here? Any things to clear up? Okay, we'll keep on going. The next area to talk about is orthostatic hypertension. And in some ways, this is the reverse. With autonomic dysreflexia, you have a increased blood pressure in the brain, blood flow to the brain. Here you have decreased blood flow to the brain. And the problem here is that we have a heart that's pumping blood into our extremities and back again, but we also depend on pumping muscles, pumping motion of muscles in the different blood vessels to send the blood back towards the heart. And if a person is paralyzed, they lack that pumping mechanism in the extremities. So the result is the blood can pool in the extremities and the person may become lightheaded, dizzy, or nauseous. It especially happens if the person's been lying down and all of a sudden they sit up. So what you need to do in this case, this is something that we can handle as OTs, although it'd be good to inform the medical personnel. You can tip the person backwards and elevate their legs. I thought I had a picture here of somebody in a wheelchair being tipped back. I think that comes later. Okay, that's orthostatic hypertension. We also need to talk about pressure sores. I'm sure all of you have worked with the problem of pressure sores, and you know it's a problem whereby the skin between a bone and a hard surface is compressed, and the result is lack of blood flow to that area. And of course, any of us, if we're sitting for too long and we press, for instance, our ischial tuberosities against a cushion, we feel uncomfortable. So we move around, we shift from side to side. But the person with spinal cord injury doesn't know that there's a cutoff of the blood flow. So the result could be a pressure sore, whereby the skin, the flesh between the ischial tuberosity and the cushion could die and cause a pressure sore. I mentioned ischial tuberosities because that's the most common place that OTs would encounter it. But of course, you can get pressure sores on ankles where there is bone close to the surface, or on heels, the back of the head. There are other places you can get the same thing. So again, OTs mainly worry about pressure sores and ischial tuberosities on the buttocks because we have people sitting up, and that's when somebody may develop a pressure sore. So what we try and do is we train our patients to weight shift to remove pressure, to relieve the pressure between the ischial tuberosity and the seat. And the guidelines say 30 to 60 minutes. Every 30 to 60 minutes, you do it for 30 seconds. Now that's a broad range. So basically the patient and the therapist need to become aware of what the range is for the particular person. If the person's been sitting up and they're developing some redness on their buttocks, then maybe they need to do a pressure sore more often. If they're not having problems, maybe a pressure sore, you can do pressure release less often. And there's some different ways of doing it. One way, if the person's sitting in a wheelchair, you can just tip the wheelchair back so the wheelchair handles are sitting on like a cushion or a mat, or held by a person, which takes the pressure off the buttocks and puts it on the back. The person can also, if they have good arm strength, they can push down with both of their arms and raise their bottom off the chair. Alternatively, they can lean to one side for 30 seconds and then lean to the other side, taking the pressure off one buttock at a time. Of course, we're also involved in prescribing cushions for a bed or a chair to prevent pressure on the ischial tuberosities or other areas, but we shouldn't depend only on that. We shouldn't say, okay, they have a cushion, they don't need to do other weight shifting. They should do these weight shift exercises as well. And I think here is one, the picture I was talking about of somebody being leaned back in their wheelchair. If they do have a fancy wheelchair with a backrest that goes down, then they can do that instead. You can just put the backrest down so they're lying flat. Any questions here on pressure sores? Any experiences you'd like to bring up of your own that would be related to this? Any problems you've had?
So everyone would have to unmute themselves if they'd like to ask a question, because I'm muting everyone to decrease the background noise.
The only thing I would say is that a lot of the patients with spinal cord injuries that I have had, I mostly saw them in lying. So I'd have to put something mostly under their ankles, not ankles, sorry, their heels actually, to prevent pressure sores, like a glove with water or something like that. Not the butt so much, but back and definitely heels. I see a lot of pressure sores.
Okay, that's definitely true. If a certain person is lying down, the buttocks are not going to have the full weight of the body, but areas like the heels where the bone is very close to the surface, there's going to be more problem with pressure sores. That's definitely true.
That's all.
Okay, anybody else? Calvin, did you have something to say?
No, not really. I've never really encountered a lot of patients with pressure sores.
Okay, good. I'm glad to hear that. That speaks well for the patients you work with in Guyana. Let's spend a few minutes talk about stages of recovery then. After a spinal cord injury, there is an acute stage. And this is when you sprain an ankle, there's swelling because the body's response to injury is to flood the area with fluid, with maybe anti-inflammatory elements. So the same thing happens in the spinal cord. But the problem is the spinal cord is encased in a bony sheath. So when there's swelling, there's no place for the swelling to go. So that puts additional pressure on the spinal cord. So what will happen is because of that additional pressure on the spinal cord, the person may have decreased function. So as there's a period of a couple of days while the swelling goes down, and there we usually should anticipate a little bit of increase in function. So maybe when they first were injured, they couldn't move their hands, but by the time the swelling goes down, they have more hand movement. And our treatment focus while the person is in the acute stage is immobilization, because sometimes after a spinal cord injury, somebody can have bony parts that might injure the spinal cord if they haven't been operated on. So we want to immobilize the patient to reduce further damage. At the same time, we also want to reduce the potential for contractures. So we need to do whether passive range of motion, exercises, and also reduce the possibility of pressure sores. So doing some of the cushioning that we've talked about. In this case, the cushioning under the ankles to prevent pressure sores in the heels would be very important. Once the person is stabilized, then they need to start working hard with exercise, with activity. At that point, the potential for spontaneous improvement is limited. The person's unlikely to get much more improvement in their function if they were left with elbow flexion but no extension. They're unlikely to get the elbow extension back. So the person needs to manage with what they have after their injury. Questions there? Okay. Spasticity. This is another issue that we need to talk about. Again, from a medical point of view, it can be treated by medicine, but OTs have an important role here. And what happens with spasticity is that we do have reflex control centers in our spinal cord. And if we have an intact spinal cord, then we're able to control these centers. The centers might spark a movement in the legs, but we can say, no, don't do that. The brain can control the reflex centers in the same way that we talked about primitive reflexes in childhood. The brain there learns to control those primitive reflexes. But if somebody has a spinal cord injury, then the connection between the brain and those reflex centers will be cut. So the person will have more spinal reflexes. It is more common in most common in people with cervical level injuries. And what it is a sudden uncontrolled contracting of the muscles. It could be elbow flexion, it could be trunk extension, so the person all of a sudden is straight whereas they had been sitting up. It could be knee extension suddenly. It can be brought on by many things. It can be spontaneous. We don't always know the reason for spasticity, but it can be brought on by some of the things that we've already discussed: skin irritation, tight clothing, constipation, any of these things that affect how the body is reacting. Even a pressure sore can be a trigger for spasticity. They can be painful. The sudden movement can cause pain. They can cause contractures. If a person has spasticity in the elbow flexors, they may have trouble extending their elbows. They can even knock a patient out of their wheelchair. They can be so strong that a person may be sitting in their wheelchair, they have a sudden hip extension and they're on the floor. Or imagine if somebody's trying to do a transfer from their wheelchair to their bed, and all of a sudden they have a violent hip extension, they may end up on the floor. Also imagine if somebody's trying to eat and they're trying to bring their hand to their mouth, and all of a sudden they have a violent elbow extension. It's going to make eating pretty difficult. So there are many different things that can be done for spasticity. One of them, there are some medications to control it. It will be our role to advise physicians on the need for this medication, but not to provide the medication. Slow, prolonged stretch, weight bearing will also help to reduce spasticity. So our role, the first thing we need to do is assess where the spasticity is. Is the person having spasticity in their elbows? Are they having spasticity in their knees? Does it tend to be sudden extension, sudden flexion? And also, how is it affecting their ADL function? Is it making it more difficult for them to sit? Is it making it more difficult for them to eat? What's the problem? We can also do slow stretching. One thing not to do is a pumping motion. A pumping motion can actually increase spasticity, but we want to extend the spastic joint against the direction of spasticity and hold it in that position for a few seconds. Then, of course, since we are OTs, we follow up that slow stretching by some functional activity, stretching out the elbow extensors and have them practice eating, maintain their elbows in an extended position. If the person has problems in their legs with spasticity, we don't treat that as such, but we can put them in a standing frame, and that standing frame will both provide some weight bearing on the legs, and also it will give a prolonged stretch to the knee flexors. So in both of those ways, it should reduce spasticity. Some patients, depending on what their level of injury is, can do weight bearing on their arms. The same way we often have people who've had strokes weight bear on their arms to normalize tone. We do the same thing for a person with a spinal cord injury affecting the arms. We do some weight bearing on the arms, leaning forward on a table, if they can, leaning to the side in their wheelchair with their arms extended. If the person does not have control over the arms, if they're not able to extend their arms, we can use some sort of a brace. These can be purchased on the internet. It can be like an air splint, which is a tube that's put over the arm and then inflated. Again, you would purchase it. Or you can do such thing as make a cast out of plaster of Paris, or take a big thick piece of cardboard, wrap it around their elbow, and fasten it to maintain their elbow in extension, and they can do some weight bearing. The other thing we do is we try and train the person how to use the spasticity in a useful way. So imagine a person who's sitting and they want to stand up. If they can trigger spasticity in their hip extensors that will straighten the body, it will be much easier for them to transfer. I also know people who have been able to walk by triggering knee extension and then walking with elbow crutches. So again, this is the last thing we do, prescribe adaptive equipment to reduce the impact of spasticity. Any questions there about spasticity?
No, it's just that it's where I work right now.
Yeah,
I don't POP to work with. So anytime a patient needs elbow extension, I would have to go to the guys that work with the POP and get them to come up. So I was trying to think of ways that I can get elbow extension without having to go to them because we don't have ear splints.
okay. So these are people who have active elbow flexion but don't have that active elbow extension?
Not always the case, or it could just be some spasticity or rigidity when
Okay.
they just can't extend their elbow for different reasons.
Okay.
And the doctors would ask me to make the splint, but the type of material that we have in the department is not really effective for it.
So what I would do is I would get a fairly heavy piece of cardboard and I would wrap it in a towel so it doesn't cause pressure on the arm, and I would wrap it around the arm. And then you can either tape or you can put string around it somehow to keep the elbows extended with a piece of cardboard that goes from maybe from the wrist up to just below the underarm. And that would maintain the elbow in extension. Do you have the option of doing that?
That sounds like a good idea. I could try that next time.
Okay. It depends on your patient. Some patients look at it and they say, why are you wrapping me in cardboard? If you can demonstrate that it helps the person, I think, they can cooperate.
Well, you've got to convince them to wear any form of splint. So
Sure. Does your department have access to plaster of Paris?
no.
Okay. Well, then you have to go with what you have available, which could be cardboard. It could even be if you had a piece of wood and you could put it along the side of the arm, again, wrap it so you're not causing any pressure, and then fasten with bandages of some sort. Basically, what you want to do is attach the arm to something that's straight to keep it straight.
Okay. I understand. Yeah.
Okay.
Thank you.
You're welcome. The last thing to say about sort of the medical aspects is that we tend to think in terms of spinal cord injury as an all or nothing thing. They have damage at the C8 level. They can use both arms, but they can't use their hands. They have damage in the lumbar area. They can use both arms, but they can't use their legs. But depending on the cause, some causes will result in a partial, incomplete spinal cord injury, especially like a gunshot wound might damage one side of the spinal cord, but not the other side. So you may have a situation where somebody can use one arm, but not the other arm, one leg, not the other leg. You could even have what they call a monoplegia, meaning that they can use both legs and one arm, but they lack movement in the other arm. Cancer can also cause this sort of distribution of symptoms. So what do we do as OTs? The first thing, of course, we do is we evaluate. That's true of any patient. We'll do a manual muscle test. We try and figure out which muscles are still functional and how strong they are. You use the manual muscle test of first seeing if the person has any sort of contracture of the muscles, then seeing if they can move in a gravity-eliminated situation. So for instance, extending their elbows, if their arms are in a horizontal plane. If they can move in a gravity-eliminated position, then we put them in a gravity-resisted position, see if they can move the limb against gravity. If they can do that, then we put them in a resisted position where they're not only going against gravity, they're also using a weight of some sort. So we try and figure out exactly, do a very careful analysis of which muscle groups are still functional and how strong they are. In some situations, people will look at the individual muscles, the different flexors of the wrist, the different extensors, the elbow. In my experience, it's generally okay to do a gross, okay, the muscles that extend the elbow, how strong are they? We're also going to test sensory capacities, whether the person has awareness of pain, whether they have awareness of the difference between hot and cold, whether they are aware of movement, whether they can tell the difference between a sharp and a dull discrimination. And these you would do with using a safety pin for a sharp or dull discrimination, using a little tube of hot and cold water to test the difference between hot and cold, see if they can tell the difference when they have their eyes closed. We'll also be testing their arms for contractures, see if they have full passive range of motion. We'll be testing how well they can transfer. We'll be testing all the different areas of ADLs, eating, washing, dressing, whatever they need to do, their work capacity. And finally, we'll be assessing their motor capacity, whether they can walk, unusual in a spinal cord injury, but possible, how well they do on wheelchair mobility, etc. Any questions there? So we've already taken about 40 minutes. So we'll keep on going for another 5 or 10 minutes and maybe 5 minutes, then open up for discussion. And as I say, we do have 2 sessions here. So we're not going to finish everything today, but we can continue on and finish the rest in February, I think it is.
That sounds great.
Okay. So ADLs, this, as all of you know, is our major role as occupational therapists. So, and it's true of spinal cord injured patients as well as any other patient. To begin with, for eating, one thing we can do is we can make them or purchase for them a universal cuff. If they have no ability to grasp things with their fingers, then we can purchase you'll see the picture here on the left, an elastic strap that goes around their hand, a pocket to put a spoon in. They still can eat, even though they don't have hand grasp function. That same pocket can also take a pen for writing. It can contain something attached to a razor for shaving. They can use that for many different kinds of manipulation. On the left is the one that's commercially made, but what I've done in the past is I've taken a strip of cloth and I sewed it, doubled it and sewed it, and then turned it inside out so you have a tube, and then you cut a slit in that tube, and in that slit you can insert a spoon handle, and then you can tie the 2 ends of the piece of the cloth around the person's hand. So that's a way of making a universal cuff at home. Now, some people may not have lack of grasp, but they may have a weak grasp. In that case, you can purchase here on the right one of these large handled utensils, or you can take their spoon and you can wrap it with cloth. You can wrap it with a piece of bicycle tire so that they have a larger handle that's easier for them to grasp and pick up things. If they do have trouble picking things up like a cup to drink, if they can use a straw, then they can drink that way. If they have trouble eating from a bowl and having food splat over the side, then if you can give them a bowl, there are commercial plate guards you can buy, or you can get a plate that or a dish that already has steep sides, and that should make it easier for them to eat without spilling. For shaving, I showed you the universal cuff. Here on the right-hand side is somebody who has an electric razor, and they've attached a piece of Velcro on the back, and that Velcro is attaching to a universal cuff, and the person then can shave with a razor, or they can put a safety razor in that same pocket and they can shave. If they're dressing, the problem is usually being able to grasp the clothing. If you can sew loops onto pants or socks or underwear, then even if they can't grab the socks or the underwear, they can stick their fingers to the loop and pull them up. And then the other recommendation we often make for people who have quadriplegia is dressing when they're lying down. Because if you're trying to sit up, it's really difficult to get your pants underneath of you if you can't stand. It's hard to get your shirt on because you have to lift your arms up in the air. But if you lie on your back, you can bend one leg up at a time and get the pants over your feet. And then you can roll from side to side to pull them up. And the last device here that we recommend is something called a button hook. Of course, if possible, we recommend that people wear clothing that don't have buttons. Much easier to pull up, to put on a shirt that opens down the front. Put on a shirt that doesn't open in the front, and they don't have any buttons to fasten. Or use Velcro or something like that instead of buttons. But on the left-hand side here is a commercial button hook, whereby the person can stick the left end of the hook through the buttonhole and then put this part on the left over the button and pull it back through the buttonhole. You can purchase that on the internet, but when I was in Guyana, one of my students, who's now an OT, Calvin, who's on this call, made a button hook like that by taking a large safety pin and attaching it to a piece of wood, and it worked just as well as the commercially made ones. Let's see. So that's slide 19. We're about 2/3 of the way through the presentation, Kate. I don't know what you think. Is now a time to do some sharing, to share some experiences? Questions?
I think that sounds great.
Okay. So let me ask you, how many of you who are on this call, how many of you have had some active work with people with spinal cord injuries?
I have some, but I can only think of two.
Would you like to talk? Who is this talking? I can't tell.
It's Erica.
Erica. Would you like to talk, Erica, a little bit about some of the patients you've seen and what issues you encountered, what problems you encountered?
Pardon me?
Would you like to talk, maybe mention one or two patients you've seen and problems you encountered?
Sure, but I can't think of anything major. I just remember.
Okay.
I just remember this one young guy that was in an accident, and he was really weak. He sustained a spinal cord injury, but it wasn't very severe. He just had a lot of weakness.
Yeah.
And he was in the ward, and I think that's just not something that I can change, but that's my major problem. The ward facilities not great for me to work, but I just did a lot of work with the physio, so we go up and see him together.
Okay.
A lot of trying to get him to go through the range of movements without his hand falling. So it's going to the range and some strengthening at the same time.
Okay.
And I would give him his juice bottle and tell him to squeeze it and try to open it and stuff like that. So,
Good.
small activities
Good.
that he could do while he was there.
Okay. It sounds like you were successful, Erica.
Yes, I actually saw him walk past me the other day, so that was great to see.
Good. That's always encouraging. How about others of you? Are there people that you've worked with, people with spinal cord injury that you'd like to talk about, problems you encountered?
Hello?
Calvin?
Hi, yes, I'm Sir David. So, well, I'm at the Palms now, and it's more of the neurological center.
Yeah.
So I would have seen a few patients, but I would not have assessed them. The physio did that.
Okay.
And I basically spoke to them on pressure sores and positioning and things like that. this one patient in particular, we tried to get him onto the National Commission of Disability so he could get his disability benefit,
Okay.
and trying to reintegrate him into society and to get a job and things like that.
Okay. Did any of these people have impaired hand function, Calvin?
No.
Okay. So if the person doesn't have impaired hand function, then our role as OT is much less.
Yes.
Okay. But it sounds like you were doing the right things, which was to help them develop the support systems they would need after they left the
Yeah.
hospital.
All right. So I think that's probably it for me.
Okay. Okay. Let me ask all of you something else. From the information that I've provided you with today, is there anything that you think will be specifically useful? Anything you could apply to one of your patients at this point?
Probably the splinting area
Okay.
and spasticity.
Okay. Good.
Because I think we have ear splints here at the palms, so we'd work on seeing how best we could get some to Erica.
Okay.
Or get one to Erica, and probably use it a lot more in the department here.
Okay. That's the kind of cooperation between OTs, not only between you and Guyana, but between people in different countries. That's really encouraging. That's what we need to see.
Yeah, I was going to say basically the same thing. The splinting part is one of the things I'm definitely going to try. I don't get to see a lot of spinal cord patients because I don't get to go to the ward often.
Okay.
Or supposed to. But I'm going to try the cardboard or the wood method and see how best I could not be going into the casting area too often.
Mm-hmm. Yeah.
Casting is more complicated. It does require some training in use of casting materials, but I would imagine there are people within Georgetown Hospital who have the expertise in casting.
Yes, so that's the thing. They would help. They're very helpful. They would come up and do it for me.
Okay.
But I just wanted to know ways that I could do it for myself.
The other thing to mention is that you can do what's called a clamshell. If you want somebody to have control over the extensors in the elbows, you don't have to make a permanent cast that they can never take off. You can put a cast on and then you split it down the two sides so it can be put on and taken off.
Ah, okay.
Yeah. Then they're able to take it off, just if nothing else for reasons of comfort, because having a cast on for a long period of time can be uncomfortable.
Yes, it can be.
Yeah.
Or what I did once was, well, not I did, but what I asked once was they use fiberglass. Is fiberglass?
Yeah.
Yes, and they made just like a back slab. I think that's what they call it. And then they wrapped the guy's arm with bandage, so the bandage could be rolled off, and then the splint could come off, so he could wear it the 2 hours on, 1 hour off. He could have taken it off and putting it on back.
Sure. That's another way of doing it, Erica. That's excellent if you have access to the fiberglass. Definitely.
Yeah, I don't. That's something that only the POP workers, technicians would have too. So yeah. I was just trying to reduce how much I would have to go to them. I'll try to see if it's something that we could get in the OT department. I'll ask the supervisor.
Okay. Yeah, because if there are patients on the ward, and this would be either on the ward or at the POMS, patients who have had spinal cord injury, you as OT should be saying, I need to be involved. There are things that I can help this person.
Yeah.
Any other questions? Any other comments from the rest of you? Is this useful information? Is it things you already know?
So David, I think Nana has a question because her digital hand is raised.
Okay, please, Nana. I'm not hearing anything. Could she type it in? Is that a possibility with the Zoom?
Yep, there is a chat box. She could type it in. So I'm not sure. I did send her a message. So
Okay.
we'll just wait on that.
Okay. And again, I would encourage all of you to look at the PowerPoint. I will send it out to all the people who got the invitation to join this session, and identify additional questions you have, identify additional areas that aren't covered in the entire PowerPoint, because we can expand, we can add them to our presentation, the next one on spinal cord injury.
Thank you.
Great, no problem. Sounds good to me.
All right. So are there any other questions before we wrap it up for today?
No, I think that would be it for me.
Yeah,
All right.
I don't have any questions.
Okay,
Yeah.
and if you do think of any, you can please email me. You all have my email, kate.barlow@aic.edu. And I can send them on to David, and we'll get you some answers. So, but thank you so much, David. This was really great.
Actually, Kate, my email address will be included on the PowerPoint that I'll send out, so they can.
Okay, great.
Yeah.
Thank you so much.
And it would be, I was glad to meet all of you on this line. Glad to talk with you, Erica, and Calvin. It's been a while.
Yeah.
Look forward to
Yes.
It has.
you all have a good day.
Regina and the Fiza could not make it because they're right now
Flight got
traveling.
delayed. Their
Okay.
flight got delayed, so they're not.
And they
They
didn't
were-
want to break all the airline regulations and get online when they're on the flight. Wasn't even worth it.
I think they'd want to come back to Guyana and not be in trouble, yeah?
Yeah, no, you're right. You're right, Calvin. Better not to be in trouble. Okay. Well, thank
All
you
right.
for joining us. And I'll be talking with you at our next session in January, if not before.
Great.
All right.
Thank you, everyone.
Okay, thank you.
Bye.
Bye-bye.